I hope that you will continue to enjoy this fascinating meeting and enjoy a good slice of cred as well. So me and my co-chair, Mr. Nanu Mensah, we would like to thank the organizing committee for this honorary invitation. Let's proceed with the next talk. Microbiota has been recently revealed as a major player and a predictive biomarker for its response to immunotherapy, but to chemotherapy and radiotherapy as well. However, its impact on carcinogenesis is also important. So at this point, it's my honor and privilege having the chance to call to the podium the ultimate judge of the quality of colorectal cancer surgery, who is going to talk to us regarding colonic microbiota as a prognostic and predictive factor in colonic neoplasia. Professor Quirke, we are eagerly expecting to listen to your talk.
Thank you. Hello? There we are. So, it's very nice to be here. We've been involved in looking at the microbiota for about 4 years, and we'll show you some of the results that we've got. But firstly, I want to take you on a journey through why the microbiome is something you need to know something about, its potential importance in the creation of colorectal cancer and even its treatment. So it's a fascinating area with a vastly expanding number of publications of variable scientific quality. But the one thing I can tell you is that you shouldn't ignore the area because it is fundamental to bowel cancer, and might be very interesting if bowel cancer turns out to be treatable by antibiotics in the way that Helicobacter has led to major changes in gastric cancer and gastric lymphoma. So, some general points here. That the GI microbiome is established in utero. That's been shown recently in Nature, and increases at birth. It's influenced by the method of delivery, whether you have a caesarean section or a vaginal delivery, because the vaginal bacteria coat the baby as it comes through, and also if the baby is being breastfed. So one of the important things is the diversity of your microbiome. So how many different types of bacteria do you have? And this increases and roughly stabilizes by the age of 3, giving rise to an individual signature microbiome. You all have different microbiomes in this room, and it's dependent upon what you eat, your behavior, your families, and a wide range of factors. But you all have a signature microbiome. And it changes with diet, drugs, antibiotics, pregnancy, and aging. So this is a changeable beast, and is something that you should look after. It's like having a garden growing inside you. You want a beautiful garden with lots of plants rather than just a bunch of weeds. So the microbiome of the GI tract is very simple in the stomach and becomes increasingly complex as we get down to the large bowel, where we see vast amounts of bacteria, 10 to the 12 bacteria. There are more bacteria in your gut than there are cells in your body. If you look at the anatomical layering of these bacteria, you see different bacteria on the epithelial surface, adherent to the epithelial surface, in the mucus layer, and then in the intestinal lumen. And therefore, getting to grips with some of the causality here means that you potentially have to sample all 3 layers in terms of understanding what is going on. But it's much more complex in the intestinal lumen, and you have good bacteria and you have bad bacteria. And then this is the age aspect. As you move from birth to a year to death, then you see that it's continuously evolving. And probably reducing exposure to antibiotics is terribly important. If you go to relatively uncontacted tribes in the Amazon, you look at their microbiota, what you see is they are immensely complex. And that's what you want for a healthy microbiota. You do not want to take antibiotics if you can avoid it, because they can cause havoc to your microbiome. What you eat is terribly important. So what your constituents are, protein, fat and fibre, all change the microbiome that you have within your large bowel, and we won't go into great detail, but if you have a lot of fibre in your diet, you end up with a very different microbiome to if you have a lot of protein. And since we have a lot of protein, that can lead through into inflammation and increased proliferation, which is not necessarily good, as opposed to a high fibre diet, where you see a decrease in proliferation and a decrease in cancer risk. So diet, terribly important, and its link through to cancer may be in part, if not a large part, through the microbiome. It's important in your gastrointestinal tract development, especially of your immune system. It's a very large immune system in your large bowel. Think of all those lymphocytes there. Think about the interactions between the microbiome, where it's so complex, and the lymphocytes within your bowel. They metabolize. These are not simply bugs that sit there. They have active metabolism and produce a whole range of things, and some of them probably influence you and how you think, your depression, and all sorts of things like that. You carry this microbiome around with you, and it also interacts with you. So again, a healthy microbiome is good for you. And you have a war going on between good bacteria and bad bacteria on the surface, but also within the lumen of the bowel. It's associated with all sorts of disease, and changes are associated with diseases. Association and causation you have to be very careful about, but certainly colorectal cancer is strongly involved in this story. Metabolic diseases, obesity and diabetes, there's some very interesting work on fecal transplants and giving rise to obesity. Is this one of the major causes of atopy and also immune diseases within our populations? That remains to be established. And then there are links through to neurological disease and the production of various brain active metabolites by these bacteria. Now, it's not just antibiotics which can play havoc with your microbiome. A wide range of other drugs can also affect your microbiome. So it's not just antibiotics, it's other drugs, and you can have other effects. And there's this very nice recent March paper in Nature which gives you an indication of what drugs affect which bacteria. Metformin, which is an important drug, affects your bacterial populations. And some of the bugs that I'm going to talk about, Fusobacterium nucleatum and Bacteroides fragilis, are actually also affected by some drugs. So, potential causes of colorectal cancer. We have variation in the populations of bacteria that you have in high-risk and low-risk populations, and the metabolic effects of those bugs on your mucosa. And important metabolic effects are short-chain fatty acid production and bile salt metabolism, and bacteria affect these. I'd just like to show you some studies which I consider very interesting. So if you take native Africans from Kenya and you take African Americans and you switch their diets, so you take the Africans and put them on a hamburger diet, and you take the Americans and you put them on a ugali, which is maize meal diet, then you change their microbiomes. And it led to a change in the microbiome itself, the fecal metabolites of that microbiome, so a reduction in anti-proliferative butyrates and increase in carcinogenic secondary bile acids as you went from an African to an American black population. And then you also can see an increase in colonic mucosal proliferation and inflammation as you move on to that American diet. And these are the microbiomes of 12 individuals, and these are the native Africans here and the American African heritage, and these are individual people, and you can see here the brown is very variable. These are Bacteroides, and this is because of the high protein diet, and these are the Prevotella, which are the fermenters, which are good bugs, which you see in the African diet. And so if we all started to eat ugali, we would have a lot more Prevotella, and we would change our fecal metabolism quite substantially. So there are higher bile acids in the Americans and lower bile acids in the Africans, and there are higher short-chain fatty acids in the Africans and this is a substrate for the bowel mucosa differentiation and suppression of proliferation. So the microbiota influence the bile acids and the short-chain fatty acids. And so there is this general population that you have within your microbiome. But there's also other kids on the block. So it's been reported recently that Fusobacterium nucleatum is associated with bowel cancer, and there is experimental evidence that enterotoxigenic strains of Bacteroides fragilis and a PKS carrying toxin E. coli are associated with increased risk of cancers in animal models. And also we've known for a long time Streptococcus galolyticus in a blood culture means you have to exclude a right-sided ulcerating carcinoma, and also Enterococcus faecalis can also be associated in that way. Now those two are associations, whereas Fusobacterium and these other two are actually experimentally linked now to bowel cancer. And what you can see here is the fact that they're not just in the bowel. Here is Fuso sitting actually in a cancer, and there's a recent publication of them sitting in metastases. This is some immunocytochemistry from our lab. Here are some bacteria reacting with an antibody to Fuso in the tissue, and here is the filamentous version sitting out there on the surface of the tumour. So we can actually find these things in tumours. Now, the other thing that's been pushed recently are biofilms. This is the mucus layer, and having been enriched in some of these unpleasant bacteria. And this is a study by Cindy Sears looking at American and Malaysian tumours and the occurrence of biofilms throughout the colon and the rectum. And here's a biofilm, and that's Fusonucleatum, a bloom of them. As you might get a bloom of algae in the sea, this is a bloom in your local mucus layer. And these are some of the other bacterial species when lit up with fluorescent in situ hybridization for different types of bacteria. And this is all work done in Cindy Sears' lab in Johns Hopkins. Now, people can demonstrate Fusobacterium both within the tissues here, not present in the normal, and also intracellularly, and that's not showing up very well, but there's a bacteria here and bacteria up there, which I apologise. You can do quantitative PCR, and we've taken the methodology of Matt Myerson and they transferred all the details, and we've done quantitative PCR. If you use a very sensitive cutoff, we find it in 2/3, both in a stage 4 set and a stage 2 set. If you drop the cutoff, then it's about 30%, which have higher levels of Fusobacterium nucleatum. So we can find it, and we can find it both in the US and in the UK. Fusobacterium nucleatum are very complicated. There's a whole range of strains, and so getting to grips with this is going to be quite complex. Do they all behave in the same way? Do they behave differently? We don't know. We do know from, this is Cindy Sears' work, looking at Bacteroides fragilis having a toxin gene, that's present both in the colonic mucosa and in the stool in cancer patients more often than controls. And she's demonstrated DNA damage in animal models, in animals that you've given Bacteroides fragilis with this toxin in. So if you have DNA damage, that can lead to carcinogenesis, so potentially important in terms of causation. And then she's also done work with this PKS toxin E. coli, and that also increases the number of tumours you see in animals, and maybe potentially another factor that we need to take into account. So is it a single bacterium, or is it the presence of multiple bacteria? Is it the presence of those multiple bacteria producing toxins over many years that leads to issues? We don't know, and so we're still in early days. We've done a bit of work on intervening in leads, and this is a study where patients were given fish oil, and there was a crossover study, and what it demonstrated was that we could see an increase in, reversible increase when you take them off, between Bifidobacterium and these other bacteria, which are positive bacteria that increase the amount of butyric acid and reduce the amount of the bile acids. So by giving people fish oil, we could demonstrate that you can actually increase the good bugs versus the bad bugs. So more of that dietary intervention is potentially possible to do. It's potentially a screening tool. It may help with the detection of blood and enhancing what we do with a microbiome profile. Here are 4 papers. Here is a paper where they have a model combining FOBT and FIT and bugs, and they increase the sensitivity. Here's another one where they increase the sensitivity in their model. These are all small numbers, and we need much bigger studies to know whether adding in the microbiome to the blood test is going to be valuable. At the moment, we've published on using FOBT cards, and we can demonstrate that we get very good relationships between fresh and FOBT stool, and it's stable over a very long period of time. We've sequenced 800 at the moment, but we need to go to 10,000 and then 100,000. So that's big money, which we don't have at the moment, but hopefully we'll be heading on our way towards it. We've got an international microbiome network set up between 3 continents, so we're going to be looking at the microbiome in different places, and we also have an under 50s study. And of relevance to the surgeon, there's a hypothesis that anastomoses may breed collagenase producing bacteria, and this is from Avery in the States, Verdi, and so we're looking in the INTACT study for collagenase producing bacteria on anastomoses to see whether treating patients with non-absorbable antibiotics into their rectum to the anastomosis might actually be of benefit to them, but that's all for the future. So direct anti-cancer effects of bacteria, so toxins, toll receptors and metabolites have all been suggested, and there's a good review here, Microbiology Nature in August 2017, if you want to read about that. There's also associations between the microbiome and immunity and the use of anti-PD-1 based immunotherapy. And again, immunology is hugely complex, and they have multiple different ways in which the interactions can occur. And again, this that's from this one, but the review of this is PD-1 in Science, showing that you can alter the microbiome in experimental mice, and you can alter the sensitivity and resistance to PD-1 inhibitors. How do we alter? Well, with interventions we can fecal transplant, antibiotics, probiotics, prebiotics, other drugs, and calorie restriction can all change the microbiome. And what you also have to bear in mind is that people with different diseases will have certain types of microbiome, and you might need to take those into account when you're looking at what you're going to do in these situations. This is very interesting. So there's a paper back in 2009 which says that if you change the diet and you increase the exercise of your post-operative patients, then they do better. And this is a very recent paper which is just out in March 2018, and it's saying that survival is related to adherence to exercise and diet within your cancer patients after treatment. Now, it isn't randomised. We need a randomised study of dietary adherence, but the dietary changes and exercise change the microbiome. So is this influence occurring through the microbiome? We don't know. So, in summary, that was a very, very rapid whiz through the microbiome, but it certainly may help us to understand and treat bowel cancer. I think we've all known that what you eat affects bowel cancer from the epidemiology over many years. And is its effect direct on the mucosa, or is the effect through the microbiome? How does it happen, and can we block it? And that's really important in whether we can prevent bowel cancer, which is what we all should be trying to do rather than treat it. We can intervene with either pills or with diet or exercise possibly to reduce the incidence of bowel cancer. Should we be doing that in the patients where we actually find adenomas on screening, or patients with the wrong microbiome? It may enhance screening. We may get a higher pickup, especially of right-sided cancers, by adding in the microbiome. Its interactions with treatment, both chemotherapy and immunological agents are very interesting and are subject to quite a few studies that have been kicked off. And then ultimately, should after operations we be ensuring that our patients are having a healthy diet, are taking exercise and reducing their alcohol consumptions so that actually they can develop a healthy microbiome which may help their immunology, which may help them to stop those cancers coming back. We don't know. Now, of course, large numbers of people have been involved in the local lead studies, but I specifically want to thank Caroline Young, a young medical pathology PhD student, Henry Wood, who's our bioinformaticist, without whom we could not have done this, Marek Taylor, who was a technician that did all the bowel cancer screening work, and then other collaborators who have helped us with materials and studies. So thank you very much.
Thank you, Professor Quirke, for this fascinating talk. So, at the era of precision medicine and cutting-edge research, we return to the Hippocratic philosophy and quote, "Let food be your medicine, and your medicine be your food." I think you agree with that.
We are what we eat.
Yes, exactly. Are there any questions?
There is a question.
We've got one up here. Mechanical bowel preparation and perioptic drug use alters the microbiome. Should we change practice to prevent this effect and possibly have better outcomes? So we have to make certain that we're collecting the microbiome 2 weeks after you've had a colonoscopy so that it's managed to restore itself. And we also need to be very careful about mechanical bowel prep because that will influence what we see in our molecular testing. We don't know whether we should be altering it, we just need to be thinking about altering it. We also ought to be thinking about whether we give absorbable antibiotics versus non-absorbable antibiotics. It's very complex, so it's possibly, but we don't know yet. And we just need lots and lots of work. This study of David James is really interesting because we're getting mucosal samples, we're getting luminal samples, and we're also getting anastomotic samples in patients who, before they have surgery, at the time of surgery, and also post-surgery, to look at the anastomoses and what's gone on. So we will have some samples which will hopefully inform us, but won't necessarily give the answer to this question.
Fortunately, there are
Sure.
I have a short comment and a short question. I mean, fantastic studies regarding risk of anastomotic dehiscence and collagenases, and a nice German randomized study in fact showed that it reduced the risk of leakage by adding oral antibiotics in. So I think that that's very fascinating. The problem, Phil, is of course we have known for many years that epidemiology has shown that if you move, but how can we change it? And if, for example, you give fecal transplantation, how long would it work if people keep on eating hamburgers and all this American food?
So fecal transplantation is valuable when you want to recreate diversity and take out the environment in which Clostridium difficile can sit. But actually, if you give somebody a fecal transplant and they revert to eating their hamburgers, then it will change. So that is not a long-term solution.
No.
And it may be that we start to treat bowel cancer like cigarette smoking. And we have to change the public health and their views of what they should be eating. We should all be eating a nice Cretan diet, as we were last night, with lots of olive oil, lots of fresh vegetables and fish and things like that.
And this night, provided we finish on time.
Provided we finish on time, so I should shut up.
Still a question for you.
Does aspirin? Yes, very important question, and it's something I've wanted to know the answer for a long time, but the study has not yet been done. And it may be that aspirin works through changes in the microbiome. In that paper, I didn't see the use of aspirin, so it doesn't help you in that story. The question about aspirin is, does it suppress the mucosal inflammation on its own, or does it act through influencing the microbiota and therefore interacting with systemic inflammation? And the answer is we don't know, and we need to know that very quickly because that's really important. So thank you very much.